Thank you, moderator. I hope that most of you have enjoyed this live surgery. Uh, could have able to appreciate all the integrities of the surgery. Still, we will have more so in the next lecture. We'll start our. Thank you very much, moderators. Thank you very much, Abhishek. We'll start our next session. Doctor, to chair the session, Dr. N.K. Singh, is he around? Dr. Rajendra, please do come. Anjit. Manish, please come.
Almost 3 o'clock, then 4 o'clock, then 5 o'clock. But ideally, sir is very expert. Oberoi sir is doing lot of surgery every day, and he does lot of live surgery all over the India. That's why he does in this manner. But ideal is, and being as a beginner, you should start from 5 o'clock, take the IGHL and capsule, put your anchor there, then come above at 4 o'clock, then come at 3 o'clock. That is a standard practice in between all of us in this orthoscopy surgeon. But sir is very expert. He did both north, south, east, west, first 3 o'clock, then 4 o'clock, then 5 o'clock. But it's technically challenging surgery. So you have to be very careful if you are doing in this manner. Thank you.
Okay. Okay. Deep Singh for his presentation.
Thank you so much, sir. Before I start, I would like to thank the organizers for having us here. It was amazing hospitality and a great function, and it's good to see shoulder arthroscopy being promoted and being taught to younger audiences. So I'm going to talk about a topic which is very basic, that is about the anchors which we can use in shoulder surgery. And so I'd like to make this big topic into a small one, and I'll try to talk on only the salient points. So a primary function of any suture anchor is to attach tissue at the proper site and maintain its position without loosening or excessive tension while physiological healing is complete. So physiological healing takes about 12 weeks. So for that time, the anchor should hold. So when we try to differentiate and try to classify anchors, anchors can be classified on two methods. First, by the material they are made, and second, on the technique which they are used. So by the material, there are 5 types of anchors, like metallic anchors, biodegradable anchors, biostable anchors, biocomposite suture anchors, and all suture anchors. And on technique, there are knotless and knotted anchors. So ideally, a suture anchor should be easy to handle. It should maintain easy pull-out strength. It should prevent any suture abrasion, and it should be absorbable without resulting in any reactions as the material dissolves. The first anchor which was traditionally used were metallic anchors. So initially they were stainless steel anchors, but they had a high rate of complications because they were encapsulated by a fibrous membrane which was rich in inflammatory cells, so we could see all these reactions. The second generation metallic anchors were titanium anchors, but again titanium anchors, they are more biostable than steel, but they are not as good as the PEEK or other anchors. So titanium, what it does not have an inflammatory response, but it still has a big imprint on the bone. So the issues with metal anchors, like I said, are migration, loosening, incarceration of the metal anchors within the joint cavity, which can cause total cartilage damage, interference with diagnostic imaging, and in case there is a revision surgery, then revision surgery becomes very difficult because they have a big bioprint and they will leave with big holes in the bone, so getting new hold in bones is very difficult after that. So next generation of anchors which were developed are called biodegradable anchors. Biodegradable anchors are anchors which will melt inside the body and will be formatted, the new bone will be formation on top of that. The first anchors in those were PGA anchors. But the problem with PGA anchors was that it caused a lot of inflammatory reaction and synovitis. So now all of the biodegradable anchors we use are PLLA. So basically they have a PGA background, but they have a poly-L lactic acid in it, so that it dissolves very slowly and has less inflammatory reactions. So the advantages of biodegradable anchors are obviously that they are they have a less print. So if there's a revision surgery, it is very easy to put more anchors. They don't interfere with any post-surgical imaging. They have improved biocompatibility and lack the need of a removal surgery, which Indian patients really love. So they are designed to be biocompatible and not to elicit an immune response. But the problem with these anchors are they are fragile. They can break during surgery. In osteoporotic bones, there can be loss of fixation during surgery. Like we just saw in the last case, an incomplete burial of anchor within the bone could cause cartilage damage every time there's a movement, and there's a possibility of anchor migration. In chronic issues, these they can have an inflammatory reaction which can cause osteolysis and cyst formation and loosening of the anchor and therefore loss of fixation. So the next anchor which is most commonly used, and most of my anchors which I use are PEEK anchors. So the PEEK is a biostable material. The reason PEEK was developed was because biostable anchors had too many complications. Now PEEK is a biostable issue. It does not dissolve in the body, it does not get absorbed, but it does not have any inflammatory reaction. So the advantages of using PEEK is, and why most of the shoulder surgeons use all PEEK, is because it has excellent performance, it has good wear and heat resistance, it has excellent chemical and biological resistance, it does not affect any post-operative imaging, it has a very stable fixation, and there are no complications which are associated with polymer degeneration. The only disadvantage of PEEK is that it does not disintegrate, it does not osteointegrate. So to develop, to make that shortcoming of PEEK into an asset, now there are newer anchors which are called as biocomposite anchors. So biocomposite anchors are composed of two things, something like a PEEK and a biodegradable polymer. The most common bioceramic material which is used in these biocomposite anchors is beta TCP. So it is beta tricalcium phosphate. As we know in trauma practices also, we use sometimes beta TCP as substitute for bone grafts and all that, because it is very similar to human bone, and its macroporosity and microporosity is osteoconductive, and it has excellent biocompatibility and mechanical resistance. The last set of anchors which can be used are all soft suture anchors. Now suture anchors are very low profile. Whenever we put an anchor, like we just saw in the last case, we have to drill in a hole and push the anchor in. But in soft tissue or suture anchors, we don't need to make such kind of drill holes. So they are minimally invasive and they have less complications. So the problem with these anchors is that they can get loose. They have to have cortical fixation. You have to put this anchor under the cortex. If you don't put it under the cortex, and if the cortex is osteoporotic, the anchor will pull out. So how this works is, when the anchor is inserted into the bone, the sleeve or the tape is cinched up across the cortical bone and creates a ball that works as an anchor. All suture anchors are being commonly used and more used because they are cheaper than the other anchors. But the thing is, we need to understand, whenever we are using these anchors, there has to be good cortical bone. If there is not good cortical bone, these anchors will pull out. So it has been shown by multiple studies that in good cortical bone, if all suture anchor is used, if the cortical bone is good, then in real clinical studies there is no difference between all suture and other anchors. But when there is in vivo, not inside the body, in studies when they have put excessive load, they have shown greater load to failure. So they fail earlier. So that is why it is important that the characteristics are understood and they are only used in patients who have good cortical bone. The last bit of, now when we go to the classification of anchors on how we are used. So all my anchors I use are knotless, like Dr. IPS Oprah just showed. Knotless anchors is a revolution when it comes to shoulder surgery, because one of the major issues with doing shoulder surgery was taking care of the knots. Now when we use knotless anchors, and they give us very good secure fixation, and it decreases surgical time by a lot. And it also eliminates the potential problems associated with knot tying, such as knot migration, knot impingement, and chondral abrasion. So people, when early proponents of knots started saying that knotless anchors fail early, but that has been proven wrong by multiple studies. Now there's a study by Matach which said that there is no difference in outcomes between knotted and knotless anchors for labral repairs, Bankart repairs, slap repair, and posterior labral repairs. However, operative times are better when it comes to knotless anchor, like we just saw. Similarly, in a double row rotator cuff repair, the study by Nemirov just exactly showed that the knotless anchors and knotted anchors have similar similar outcomes in 2 years follow-up. So when we put about anchor placement, we need to understand whatever material we are using, we need to put the anchor in an ideal way, otherwise the rates of complications are going to high. As Sir just showed, the first anchor is essential to, in a labral repair, it is essential to establish the appropriate capsular tension and should be placed at 5 o'clock position. The hole should be at the face of the cavity, of the glenoid cavity, 1 to 2 millimeter for the margin, and you should be putting the anchor with a slope of 45 degree. Sir did in a lateral position. I do it in a beach chair position. So in a beach chair position, we can actually use the anchor to put a little bit of force on the humeral head so that we can insert it in a 45 degree angle. In a screw-in ankle, it should be screwed with general motion and should not be hammered in, because any forceful manipulation means that we are doing something wrong and there's a high chance of the anchor breaking. If you are in any doubt during surgery that the anchor is not well fixed or the ankle might pull out, it's better to replace it, redo the step, and not leave that anchor as such, because the chances of failure are high then. I'll just quickly close. So the take-home message here is that surgeons should consider the quality of bone, predictable complications, material-related adverse reactions, and need for potential future revision surgery while determining the most appropriate anchor. There is no best anchor. It is all dependent on your clinical circumstances. With that, I would like to end this talk. And at the end, I would just like to seek your support. We are bidding for IACON 2025 in Bhubaneswar. So any of you who are IOA members, please, when it comes to the bidding, please do vote for Bhubaneswar as the venue for the IACON 2025, and we'll make sure that the hospitality is great. Thank you so much. Any questions?
Yeah, any questions from the audience? Okay. No questions. Thank you. Thank you, Mr. Sandeep. Now, our next speaker is Dr. Mahesh Prasad, sir. Next wala? Okay. Dr. Ravi Kumar, please. Dr. Ravi Kumar, thank you. He is going to talk on Hill-Sachs lesion and remplissage.
Good afternoon. I'll talk about Hill-Sachs lesion and the remplissage. So we'll go through the Hill-Sachs lesion, then assessment of the risk of the Hill-Sachs lesion, treatment strategy, remplissage, and the literature review. So this entity was first characterized as a line of condensation on a radiograph by two American radiologists, Harold Hill and Morris Hatch, in 1940. Hill-Sachs is basically, it's a defect in the posterior superior lateral part of the humeral head, and the prevalence after initial dislocation is close to 70%, and it's close to 90% after recurrent dislocations. It can present as an isolated lesion or in association with a glenoid bone loss, in which case it is referred to as a bipolar lesion. So coming to diagnosis, history of a traumatic event, we need to evaluate risk factors for recurrence like convulsion, tendency to fall, involvement in activities that necessitate external rotation and abduction. Assessment should be made for instability, laxity, and concomitant soft tissue injuries. There are two important tests, apprehension test and shift and load test. Coming to imaging, plain radiograph, AP lateral internal views indicates the or visualize a defect. There are a couple of special views which are important to demonstrate bony Banker's or Hill-Sachs lesion, but it's always very difficult to get these special views in acute injuries. Next comes the CT scan with a 3D reconstruction. It's regarded as a gold standard. Coming to assessment of the risk factor, risk of instability caused by Hill-Sachs, there are two options. One is a dynamic examination, which is done during the arthroscopic surgeries, and the next one is a glenoid tract evaluation. The objective of the dynamic examination during arthroscopic surgery is to assess whether there is a remnant risk of engagement after the Banker's repair. So there are a lot of investigators who perform this dynamic examination before the Banker's repair, and there are a lot who do this dynamic examination after the Banker's repair. So we need to see what happens when we do before the Banker's repair. You can make out over here, there is a Banker's tear. So whenever there is an anterior translation of the humeral head, the head translates anteriorly during the dynamic examination, it will engage and become an off-track lesion, and the head dislocates. So this is what happens when there is a Banker's tear and we are doing dynamic examination prior to the repair of the tear. So the same examination, when done after the Banker's repair, the Hill-Sachs lesion does not engage. This is a Hill-Sachs lesion that won't engage because the shoulder is stable after the Banker's repair. But yes, if this is when the Hill-Sachs size is same as this one. But when the Hill-Sachs size is large, this, as is in this picture, this Hill-Sachs lesion is not covered by the glenoid after the Banker's repair, and this may engage and the head may dislocate even after the Banker's repair. So but the disadvantage of this method is that there is a risk of damaging the repair during the dynamic examination, especially if we are doing this dynamic evaluation after the Banker's repair. Coming to a glenoid tract, it's basically area of the posterior. This is the area of the posterior humeral articular surface which comes in contact with the glenoid when the arm is in extremes of abduction and external rotation. So how do we quantify a glenoid tract? There are two methods to estimate original glenoid shape. The first is the best fit circle method, and the other is to use the contralateral glenoid as a reference. Both the methods use a NFS 3D CT cuts, but if you go by the literature, using the contralateral glenoid as a reference is always better than a best fit circle method. Sir has already described a glenoid track. So when you take a in-phase 3D cut view of the glenoid, linear measurement is taken of the maximum width of the glenoid. And normally the glenoid track is 83% of the width of the glenoid. So any defect, as seen here, any defect as compared to the normal size is subtracted to obtain the glenoid track. So glenoid track will always be 83% of the diameter of the glenoid minus whatever is the bony loss over the glenoid. Next is Hill-Sachs interval. Hill-Sachs interval is Hill-Sachs defect plus the bone bridge. This is the Hill-Sachs defect plus the bone bridge, which is present between the rotator cuff attachment and the lateral aspect of the Hill-Sachs defect. So the Hill-Sachs interval is sum of the Hill-Sachs defect plus the bone bridge. So for a on-track Hill-Sachs defect, this Hill-Sachs interval should be less than the glenoid track. And for an off-track Hill-Sachs defect, Hill-Sachs interval is always more than the glenoid track. This is another pictorial representation of a on-track and off-track. This is a Hill-Sachs lesion, and this is an off-track Hill-Sachs lesion, which engages and the head dislocates. So what is the treatment strategy? For shoulders with an on-track Hill-Sachs lesions and glenoid bone loss of less than 25%, only a soft tissue repair is sufficient. With an on-track Hill-Sachs lesion and a glenoid bone loss of more than 25%, the glenoid bone loss needs to be fixed, for example, for the Letarget procedure. But if it's an off-track Hill-Sachs lesion and the glenoid bone loss is less than 25%, there is an option for both remplissage and Letarget. Letarget is always preferred if the patient is an active athlete involved in overhead activities, because it provides, it makes a off-track lesion into an on-track lesion. With off-track Hill-Sachs lesion and the glenoid bone loss of more than 25%, the glenoid defect needs to be fixed with a Letarget plus minus remplissage. Coming to remplissage, it's a French term meaning to fill in. So the remplissage stabilizes the joint by attaining two objectives. The first purpose is to transform an intra-articular Hill-Sachs lesion into an extra-articular lesion. And second is that infraspinatus tenodesis, it basically acts as a check-in or seat belt against the anterior-humeral head translation. That's how is the remplissage performed. So the arthroscopic remplissage technique with Bankard's repair is considered to be an effective, safe, and reliable procedure for the treatment of glenohumeral instability in cases with large and medial Hill-Sachs defects. If we go by the literature, majority of the literature documents that after remplissage, patient will have restriction of the external rotation. But of late, there is a publication recently in February where they compared the results of patients who underwent Bankard's repair with or without concomitant remplissage for treatment of shoulder instability. And they found that we can expect shoulder motion and post-operative outcomes similar to those of patients without engaging Hill-Sachs lesion who underwent Bankard's repair without concomitant remplissage. So they found that the range of motion, we can have a similar range of motion with or without remplissage. Thank you.
Dr. Rabi, for your presentation. Now may I call upon Dr. So, any
Doing this dynamic examination after the labral repair is really a risky job because of two reasons.
Yeah,
Because that may damage your labral repair. Secondly, it's very difficult to put the remplissage anchor after the repair, because if your labral repair is good, then after that the visualization of the defect becomes very difficult.
I know.
So ideally, I think it should be done pre-operatively, that dynamic assessment of the track, whether it's off track or on track, before
That's
the
what
labral repair. Yeah.
majority of the people do.
Yeah.
We do the dynamic examination before the Bankard's repair, put the remplissage anchored, do the Bankard's repair, come back, and then tie the knot for the remplissage.
That's the most conventional way.
But the literature supports that dynamic examination should be done after the Bankard's repair.
Yeah, but practically it becomes very difficult for us
Yes.
because we cannot. It's very difficult to put the anchor after the
Yes,
repair.
because of the visualization.
So it's better to do it before that.
So Rabi, it's all discussion of Joshi sir, your talk is whether it should be done by soft tissue method or whether it should be done by bony procedure, any recurrent dislocation of the shoulder. So there is on track, off track, CT scan measurement, MRI measurement, all we have. And we all know the reporting of radiologists in Patna also, what they write. So again, my question is the same that was at the time of live surgery. Is there anything that we can predict by clinical history and examination that this patient need bony procedure or this patient don't need bony procedure?
So history of recurrent shoulder dislocations, if the patient is having recurrent shoulder dislocations, it's most likely to have a bony Bankers involved.
Yeah, so every will have bony. So basically the examination is that is called as mid-range instability. That was well popularized by Dr. Jody Beer. What he say, at lesser angle of abduction, like less than 90 degree, at 45 degree of abduction and 45 degree of external rotation, not like this. At this angle only, if this patient is having apprehension, it means no any soft tissue procedure is going to treat this patient. This patient must need bony procedure. It means the defect of the glenoid and defect of the heel sacs is big. That's why at even 45 degree of abduction and external rotation, this patient is having instability. So this is the very basic test you can ask in every recurrent dislocation of the shoulder. And I'm telling you, if defect is more than 25% or heel sacs lesion is very big, you will find even mid-range instability test is positive. So in that procedure, straight go for your Letarjet or iliacus bone graft.
I think you have told about tests. That is very fine. But what I know, if a patient complains of dislocation, why is he sleep? He's sleeping. Most likely it is a bony bend. From history.
Sir, may I request our chairman to give a memento to our speaker, requesting Dr. Ravi Kumar to come to the dais and have a memento. आ जाए भाई दो ही स्पीकर 3 मिनट चेयरमैन इसलिए नजदीक आएगा and a moment to Dr. Sandeep. One of the talk of this session, most probably will move to the next session. May I request Dr. Bharat Singh, our past president, to give a memento to our chairpersons. तो क्या मैंने immediate past president हाँ सामने Excellent. Thank you, all chairpersons. We will rapidly move on to our fourth session. I will request Dr. Bharat Singh sir and Dr. Anil Kumar to kindly come to the dais to chair the session.
Now we are starting fourth session. Speaker is Professor S.S. Jha and subject is posterior shoulder dislocation. Lessons to learn.
Good afternoon. Thank you, Chairman, sirs. Well, I'm here just to tell you in one line that there is another dislocation apart from the very common anterior dislocation of the shoulder, and we are likely to miss it. So maybe if you remember that I was here making you aware of this dislocation, this is posterior dislocation of the shoulder. So friends, a patient with posterior dislocation of the shoulder goes to the emergency room because he is having nagging pain. The shoulder is immobile, and the resident present there gets this X-ray and unfortunately says, you have a normal shoulder. Please, please do not forget that this is not a normal shoulder. So awareness of existence of posterior dislocation is one which you should get reminded that you do not miss the posterior shoulder. Now remember this electrical bulb. In this particular AP X-ray, there is no neck visible in the head of the humerus, below the head of the humerus, and it appears as if this is a straight light bulb like humeral head. So there is loss of profile of neck due to internal rotation. Friends, on the other side, there is a normal shoulder, and the right side, this is a shoulder which is lying in posterior dislocation. So, on initial examination, there has to be high index of suspicion. A patient coming to you in traditional sling position, you might not recognize it. So what is the typical position? There is no striking deformity. That is very much essential to know. You on examination will get a palpable mass on the posterior aspect. Anteriorly, the shoulder is flattened and the coracoid is prominent. There is a limb is lying in adduction, flexion, internal rotation, and there is limited external rotation and limited anterior forward elevation. Pearl 3. History, as we have been enumerating, Dr. Arvind was telling so much about the importance of history. And I keep on telling every time that history is very important. I say talk, talk, and talk to the patient till the patient gives you the diagnosis. It is true for any part, and so true that you do not miss your posterior dislocation. So mechanism here is very important. Electrical shock, convulsion, or seizure are indirect mechanisms, and they are mostly responsible for production of posterior dislocation of the shoulder. There is a famous joke that a patient reported to the orthopedic outdoor, and it was written in the history sheet that this patient had electrical shock and thereafter had convulsion. The resident sitting there thought, oh, this must be a case of posterior dislocation. But it was not. But this joke should always keep you reminded that you have to look into the possibility of posterior dislocation. Now friends, why does posterior dislocation take place following either seizure or convulsion or electrical shock? Because most probably the internal rotators, especially pectoralis major, subscapularis, and latissimus dorsi, the internal rotators are more powerful than the external rotators. Well, radiography is the key, and remember that there is a normal elliptical overlap between glenoid and head. But one X-ray, one view X-ray is almost no X-ray though we are used to diagnosing anterior shoulder dislocation by only one view many a times. So here is one where we must have axillary view. Unfortunately, when we send our patients, just now Professor Bharat and we were talking, they will send you a radiograph with 90-degree abduction. So learn how to get a true axillary view. So look for also humeral defect, and we have been talking about heel sac lesion. Here also there is a heel sac lesion, maybe in lighter vein I would say think of sac heel lesion, but that is not the real word. It is a reverse heel sac lesion. This is impaction fracture of anterior head by posterior rim of the glenoid. Well, there can be a void in the glenoid fossa due to either inferior or superior displacement of the head. As I was telling you, real axillary view must be seen, and this is one which is usually done. So this should not be done. How it should be done? Cassette is put on the superior shoulder and direct the X-ray beam between the thorax and abducted arm. Reverse heel sac lesion can be visible in this view. Now talking about close reduction. Supine position, apply traction to the abducted arm, gently lift the head onto the glenoid. Do not use force and do not forcefully externally rotate, because there could be an impacted fracture which is locked on glenoid rim. So axial traction plus lateral traction has to be given to the upper arm, which unlocks the head. And friends, lastly, we must know when to operate. Close reduction can be achieved up to 6 weeks and sometimes even up to 3 months. The indications are wherever there is an associated fracture, like widely displaced lesser tuberosity fracture, large posterior glenoid fragment, irreducible dislocation, impaction fracture of the anteromedial head, humeral head defect, open reduction, and late presentation. I am talking about this one particular patient who presented after 3 months and we had to get operated. Next 1 minute please. Yes. Another case, this has a fracture in the anteromedial part, it had to be fixed. So the take home message is recognize light bulb sign. There should be high index of suspicion because the patient is in sling position. History becomes important. Radiography and especially axillary view should be must, and close reduction can be achieved up to 6 weeks. Surgery, look for displaced fracture, and late presentation more than 6 weeks. Thank you very much.
Thank you very much, Professor Jha. Any question? Sir, no question.
Thank you very much, and I only wish that we do not miss. Yes, Dr. Arvind. If there are no associated fractures, there is not a defect in the humeral head also, and and the presentation is late, you still try beyond 6 weeks to closely reduce it, and if it is not possible, you should be ready with open reduction. But you have to be conscious, you must be ready, as all of you have been talking about, that the defect in the humeral head, to what extent it could be repaired. So up to 40% you can repair it, beyond 40% difficult, and if it is very, very late, you can have to think of joint arthroplasty. Right.
Thank you, sir.
Thank you.
Thank you very much. Dr. Arvind Prasad Gupta. The subject is treatment option for irreparable rotator cuff tear and reverse shoulders arthroplasty.
Without wasting the time, my topic is irreparable rotator cuff treatment option and more focus on reverse shoulder arthroplasty. So basically again I'll focus on the clinical history and examination. Let's see what this patient say, what this patient is talking. So there is movement, but ये बोल रहा है कि उठ नहीं पाता है, इधर नहीं ले जा पाते हैं, इधर नहीं ले जा पाते हैं, and pain होता है. So these four symptoms are the thing associated with rotator cuff tear. That is inability to lift, forward bending there will be difficulty, at the same time patient will have pain. So this was a case of rotator cuff repair. You have seen that he is lifting arm. At the same time another patient you can see here, while doing abduction he is lifting whole of his scapula and tilting the body. While doing external rotation, internal rotation again he is tilting. While doing external rotation he is tilting whole of his body. It means there is rotator cuff tear, but symptom is very severe, and this condition is called as pseudoparalysis. By seeing it, it looks like there is paralysis of the shoulder joint. There is full passive range of motion is there, but actively hardly she can do any movement around the shoulder. But there is no neurological involvement. It is because of rotator cuff tear that is very massive, severe and irreparable. So this was the MRI of this patient. You can see the cuff has gone to the level of glenoid here in all the view. So a classification has been given. If it is till the level of glenoid, this is called as massive cuff. Next, in the axial view, you should look for the bulk of the muscle of supraspinatus and infraspinatus. There is lot of fatty infiltration in the muscle. If there is full bulk, then it should be completely black. But you can see black is hardly less than 50%. So the classification was by Gotelier, and I am making it more simple. This is the line. If supraspinatus is above the line, then there is no any fatty infiltration. And if it is quite less than 50% of the muscle bulk is there, then it is severe fatty infiltration is there. So it was grade 4 fatty infiltration. And there is MRI finding also that will tell about whether this cuff is repairable or irreparable. So this was the X-ray of this patient. There was no any arthritic sign in this patient. Only she has massive cuff tear with lot of fatty infiltration. So what are the treatment options? That is my topic. So it has started with the partial repair. If it is something like that, you can do the margin convergence, and whatever you can repair, you can do repair. So this margin convergence repair was popularized by Stephen Burkhardt with very good result with this also. If you cannot do complete repair, you can do margin convergence and do partial repair with more than 70% satisfaction rate by the hand of Dr. Stephen Burkhardt. Another thing, you can take the patch. Suppose your cuff is coming till here, so you can do the patch, augmented patch over the cuff, and you can do the complete repair. Next is the capsular repair, superior capsular repair, that a patch that connect with the glenoid to the humeral head. So this prevent the superior migration of the humeral head. That is the main pathology of irreparable rotator cuff tear, because may leads to the arthritis. At the same time, this help in getting abduction also. Next option is the tendon transfer. Latissimus dorsi is there, teres minor, pectoralis major. And the last is, all these previous were the joint preserving surgery. And the last is reverse shoulder arthroplasty. It's the joint replacement surgery. So my case was this, complete cuff tear with fatty infiltration with no arthritis. In this case, I did reverse shoulder arthroplasty because 62-year female, middle class family, the superior capsular repair is very costly. So I don't, and at the same time, rehab continue till 1 year for SCR. That is the message has to be keep in mind of everyone. Superior capsular repair needs at least 1 year time to come to go for full function. But by doing this reverse shoulder arthroplasty, within 1 to 2 months he can perform her kitchen activity and daily routine activity. So that is the difference. So what patient we are getting in our scenario, we have to consider that also. So no arthritis, only massive with fatty. I did this rotator reverse shoulder arthroplasty. So I'll come to the some basic principle of this reverse shoulder arthroplasty. So in reverse shoulder arthroplasty, the main thing is the deltoid that works. You can see here in the abduction how this deltoid is working. So this is the basic principle. This is the humeral head, center of rotation of the shoulder joint is somewhere here. In reverse shoulder arthroplasty, the concave glenoid get converted to convex by glenosphere and the convex humeral head become concave. So reversal of the anatomy. So sometime you can do better than the nature what you have given to you. That is the reverse shoulder arthroplasty is the best example of that. You have just reversing the nature and having better outcome. So this is the center of rotation in reverse shoulder arthroplasty. This center of rotation coming somewhere here. So get medialized as well as inferior also. And see how this mechanism happen with this. This is the moment arc that get increases when your center of rotation move from here to here. At the same time, the force also get increases. Here this is the force, here this is the force. And also the working length of deltoid also get increased. So three things happen here that give you the full abduction even there is no supraspinatus and infraspinatus is here. So this length of deltoid get increased. And you can see here how there is evolution of reverse shoulder arthroplasty. Just 1-2 minutes. So this was the Gremont that given the concept of this first design. This was inferior and medial, but because of quite inferior and medial, there was notching here. So you can see it was the 155-degree angle, and there was notching was there. So now there is further 135, 145-degree angle was here. At the same time, there was little bit more lateralization of the center of rotation by increasing the depth of this. And further fully lateralized, but you can put the insert over the flat thing so that it will remain as it is lateralized, but there will be no any notching. So this notching was there. So now 145 or 135, this was the concept. Again, and also the repair of subscap is very important if you can do so that the couple force that acting over the center of rotation become fine. So this was the case after 2 months of that case, and you can see only after 2 months how much she can lifting the shoulder joint. So at this stage she is performing all her kitchen activity, doing routine activity. So such type of patient is in our scenario. And superior capsular reconstruction needs almost a year for gaining full function. This was another patient. Again, this is the arthritic shoulder. You can see here, and you can also see the cuff tear with fatty infiltration also. So if there is any arthritic, you cannot do any joint preserving surgery. So in that case, again, reverse shoulder arthroplasty was performed. You can see there is hardly the inferior tilting of the glenosphere. At the same time, tilting is little bit inferior. So hardly any notching with that. This has to be keep in mind when you are doing reverse shoulder arthroplasty. Only after that your joint will last longer. Thank you. And with all these, I am inviting you all this pediatric foot ankle enclave at Paras Hospital. with BOA and this Orthopedic Research Foundation group at 17th and 18th June. You all are invited there. Thank you.
Thank you, Dr. Arvind. Now, any question? Thank you, Dr. Arvind. Next speaker is Master Orthopedic Surgeon, Dr. IPS O'Brien. And the subject is massive rotator cuff tear with tips and tricks.
Friends, it was an excellent experience in the theater. We really enjoyed it. Let me just search my file. इसमें कहाँ से मिलेगी यार? हाँ, ये एक दूसरे के ऊपर ना ओवरलैप हो गई थी एक्चुअली. हाँ, ये आ रही है. चलिए. So let's talk about massive rotator cuff tear. Okay. So let's define rotator cuff, which is a massive tear. Whenever two or more the two tendons are torn, and they are torn completely, it is actually termed as a massive rotator cuff tear. So supraspinatus, infraspinatus, subscapularis and teres, two or more than two are torn completely. They are rotator cuff tear which are massive. The thing is that the function of a patient with a massive rotator cuff tear is different. His prognosis will be different and surgical outcome will also be different from a normal rotator cuff tear. इसीलिए massive rotator cuff tear identify करना ज़रूरी है. When to suspect that the patient has got a massive rotator cuff tear? जब भी small rotator cuff tear होगा, तो what will be the problems? Problem will be pain, inability to raise the arm and weakness. But when there is a large cuff tear, the pain is usually not important. It's dysfunctional. He is not able to raise the arm at all. He is unable to reach the side pocket and his pain is less of a concern. तो आपके पास patient आता है जो हाथ उठा ही नहीं पा रहा और आप हवा में हाथ उठाते हैं और छोड़ते हैं और गिर जाता है. Start thinking about a massive rotator cuff tear. Now, also examine the patient from back. If there is a weakness in the supraspinous fossa and infraspinous fossa, it might be a rotator cuff tear which is massive. Supraspinatus भी गया और infraspinatus भी गया. Contrary to single tendon tear like जैसे infraspinatus की weakness है. So there is an isolated infraspinatus weakness. On this side there is weakness of both supraspinous and infraspinous fossa. Suspect a massive rotator cuff tear. There are three red flags which are important when you examine the patient. Raise the arm, leave it, he drops. Drop arm sign. One important sign of a massive rotator cuff tear. Number two is external rotation lag test. Take the patient's arm in external rotation, ask him to hold it. He won't be able to hold it. हाथ ऐसे चला जाएगा. This is a very prognostic important sign of a massive cuff tear. Take the arm in external rotation, ask him to hold it. यहाँ रोक के रखो. Once there is a massive tear, the arm will just go. और तीसरा horn blower sign. जैसे गाड़ी चलाते हैं, horn blow करते हैं. Ask the patient to do a horn blowing test like this. He won't be able to do it. ये drop कर जाएगा. So if these three red flags are there, a drop arm sign, a ER which is unable to hold and it comes back, this is called ER lag test, and a horn blower which is unable to do it, it just falls down. Three red flags, think about a massive rotator cuff tear. Now where does the massive rotator cuff become dysfunctional? कोई भी rotator cuff होता है जिसमें humeral head has to be centralized on the glenoid, आगे से subscapularis और पीछे से infraspinatus एक force couple बना के रखता है. It centralizes the humeral head on the glenoid. So even if supraspinatus is completely torn, deltoid with force couple, patient will able to raise the arm. But if the tear of supraspinatus has extended to subscapularis or to infraspinatus, that force couple is gone. Now patient is unable to raise the arm, it just drops down. So force couple is important. How to suspect on an X-ray? Simple X-ray से भी massive rotator cuff tear diagnose कर सकते हो. See this X-ray. Reduction of the acromiohumeral distance. Number one. Empty sign, empty glenoid in the lower part. Number two. Sclerosis of the undersurface of the acromion, also called as an eyebrow sign or a sorosal sign. एक eyebrow की तरह बन गया है. And sclerosis of the tuberosity and an osteophyte. If these five signs are on a plain X-ray, reduction of the acromiohumeral distance, empty glenoid in the lower part, sclerosis sign of the undersurface of the acromion, sclerosis of the tuberosity and an osteophyte, think about a massive rotator cuff tear. Do always an MRI to suspect how big the tear is. Now again red flags. If you have a patient which is older, you have to do something to get his movements back. If the symptoms are longer, again it's a difficult surgery to be done. If patient is overhead worker, again you have to start thinking. And if on an X-ray the AHI, the acromiohumeral distance is less, you have to really think that this case might not have good results. So how exactly to do it? A massive rotator cuff tear. These are the 4 problems with massive rotator cuff tear. Number 1, it's a chronic tear. Usually massive are chronic tears. Number 2, fatty degeneration happens. Number 3, chronic retraction is a problem. And number 4, arthritis would have happened. See each step one by one. Retraction of the tendon. This is minimally retracted tear. This is massively retracted tear. But retraction is not important. I have seen patient even after 6 months, they seem massively retracted. You go in, you hold the tendon, it is reducible. So retraction is not important. Retraction only just gives you an idea how chronic that tear is. But that does not mean that we cannot repair it. You can repair even a retracted cuff tear. So as I told you, all massive retracted tears are not hopeless. See here, actually the tendon has torn and gone inside the joint. Humeral head, glenoid, tendon piece is gone in. It actually looks like absent tendon, but it actually has broken and gone inside. So all retracted tears, don't worry, you can reduce them. Problem is fatty infiltration. That's the outlet notch view. This area is occupied by supraspinatus. See how the supraspinatus has become atrophied. If there is a fatty atrophy, that's our concern. And that is why a tangent is drawn from the superior part to the posterior part. See how much is the occupancy ratio of the tendon. If the occupancy starts to fall down, which means it is retracted and has fatty atrophy. See the tendon, nice and sitting, around 80 to 90% filling. See the tendon, very, very small, all fat. So if there is fatty atrophy, then it's a cause of concern. Now people think bigger the tear, do a mini open. No. More big the tear, the more easy it is to do arthroscopically. And we'll show you small videos to show it. You see, that's a cuff tear which you can see here. If you look here, it seems like a retracted cuff tear. But you hold it, you are able to reduce it. It's important to identify the flexibility of the tear. See which direction the tear reduces. Anterior part of tear is reducing like this. So it looks like a crescent-shaped tear, but it is not a crescent-shaped tear. It is a reverse L-shaped tear. So you're going to hold that apex and bring it here, see here, and you are able to reduce it nicely. It's an L-shaped tear rather than a C-shaped tear. So arthroscopy helps us identifying whether it is a C-shape or an L-shaped tear. L-shaped tear are easily reducible. So apparently it look like a bad tear, but see how you are able to reduce it nicely and then stitch it back to the tendon. So always access for the reducibility of tear, and arthroscopy does help on that. Number 2, case cuff excavation. Chronic cuff tears get stuck. They get stuck both superiorly and inferiorly. So that's a chronic cuff tear. Doesn't seem that you will be able to repair it at all because the tuberosity is all exposed. You go under the cuff and just elevate this area. This is the biceps. You are just going under the cuff, removing the adhesions from under the cuff. Once you remove the adhesions from under the cuff starts to become mobilized. So you have to reduce these adhesions. These are anterior adhesions which are happened. You have to release the coracoacromial ligament and the coracohumeral ligament. And when you release these ligaments, the cuff starts to retract. And then you release over the cuff. So you have reduced under the cuff and over the cuff. The step is called as cuff excavation. You excavate the cuff out. So I'm working under the acromion, cleaning the adhesions between the acromion and the cuff, and now the rotator cuff has started to float. Before it was just stuck, and now it has started to float. You prepare the tuberosity and you are able to reduce the cuff nicely back. See, holding it and after excavation, reducing it nicely back. So excavation of cuff is also important to treat massive cuff tears. And number 3rd trick which you can do is medialize the insertion. Instead of inserting the rotator cuff on the lateral part, you actually medialize the insertion. So when you medialize the insertion, the tendon pressure on the cuff goes. So you medialize the insertion, I am putting an anchor and then I am taking these threads out and now taking a bite into the cuff and taking the bite out. So you are able to reduce this cuff nicely now. Now you are able to reduce this cuff nicely. I am going to pass all these 4 threads into the tendon and reduce it nicely. So medialization of the footprint is also important. So bigger the cuff tear, easy to mobilize, easy to reduce, and reduce it medially as well. And number 4 trick is called as margin convergence. What is margin convergence? If you have a large tear which is like this, a C-shaped tear, instead of bringing the apex to the humeral head, we stitch side to side, side to side, side to side. It is a very simple technique of passing an instrument from posterior, passing the thread, and then anterior, like this, and then closing it side to side. It is something like a VY plasty, which you used to do for plastic surgeries. Instead of bringing the apex here, you just start side to side repair, and then the tear size becomes very, very small. So this is a side to side closure. Now the last step which is there is a biceps augmentation. You see, now you see this picture, you have an MRI here, there is no rotator cuff, the humeral head is exposed completely. But the age of patient is only 55. In 55 you can't do a reverse shoulder. Arvind, you would believe that. You see, he showed patients with reverse shoulder good function, but at 55 you can't do a reverse shoulder. Also, there is no arthritis in the shoulder. When you don't have an arthritis, how to do it? So when there is no rotator cuff in this patient, in a chronic 6-month-old cuff tears, how exactly to go ahead and repair these is biceps SCR augmentation. I'm just showing you a picture of a 6-month-old tear, a massive cuff tear. There is no cuff which is here. But what is good point about it is a nice biceps tendon which is there. So what we basically do is, we actually cut the biceps from the front and take the biceps, and the biceps will work as a superior head humeral stabilizer. So see, this is the cuff tear which is there, and that's the bicep which is there. The cuff is massive, we can't reduce that cuff. So what we are doing is putting an anchor, simple anchor here, taking the biceps and bringing the biceps onto the superior part of the humeral head. So I'll take a bite into the cuff posteriorly first, reduce the cuff posteriorly, stitch the cuff in the back. So infraspinatus is stitched. I have taken the bite in the posterior cuff and stitched it nicely so that the infraspinatus covers a part of the humeral head from the back, and from the front we will have biceps. So that's the last knot I am tying, and that I cut it. So infraspinatus I have put it and covered it. Then I take a bite into the biceps and bring the biceps from the front. So you can cut the biceps here and bring it, or you can just what is called as a biceps transfer in continuity. You release the biceps groove, you put an anchor, you bring the biceps on the head of the humeral head. You redirect the biceps, which was actually in the front, which is like this. You shift the biceps on the superior part. It works as a humeral head depressor. So that's how the biceps is sitting. You are augmenting the repair, the complete repair posteriorly with the biceps which has been brought up. Now that whole thing is covered, which was all exposed is all nicely covered, and actually patient gets the function very nicely back. So in these kind of irreparable cuff, instead of using a fascia lata here, which is called an SCR, superior capsular reconstruction, you can actually use biceps to do it. So concluding points, friends, whenever you have a cuff tear where there is a drop arm sign which is positive, ER lag test which is positive, and a horn blower test which is positive, suspect a massive cuff tear. You have to differentiate them from irreparable cuff tears. In irreparable cuff tears, there is a fatty degeneration. You can't repair. But if there is no fatty degeneration, then you can still repair, and they are repairable. You have to modify your surgical plan. 3 steps. See how the cuff is sitting, mobilize or excavate the cuff, and medialize your insertion. Don't try to pull it all the way lateral. Medialize your insertion. There is always a biceps tendon which is there. You can always use that biceps to do an SCR. RSR or reverse shoulder is rarely indicated in massive cuff tears. It is actually indicated in irreparable cuff tear. So in your terminology, you have to differentiate between massive and irreparable. Irreparable, you do an RSR, reverse shoulder. Massive cuff tears, there are tricks to repair it. So follow those tricks and you will be able to do it. Thank you very much.
Sir, one thing I would like to say, this is the one talk left, which is assigned to me, and I convey this to talk you for this topic.
Perfect.
And topic is intra-off difficulty and in Bankard's repair and how to tackle this situation.
Okay, I think, Mahesh, all these things were covered during surgery also, but let us revise all the steps which you are asking. We did a Bankard. So couple of things which we took important so that complication doesn't happen. Number one, I told you, you see distension of joint is very, very important. You can't pull it too hard also, because if you pull it too hard, then the glenoid, the socket actually completely dislocates. Then it is very difficult to repair it. You have to gently do a traction, and there your assistance is also helping in traction. So you have to make the position of the humeral head in a way that you are able to work. So number one is positioning of the patient. We were talking about positioning. Important that patient is not lateral. We call it lateral position. It's not lateral. Patient is actually sleeping like this. He is slightly inclined like this, so glenoid is flat. So that is number one. Number two, the traction has to be very slow and controlled. You can't put lot of traction, you can't leave it very loose. So it has to be controlled traction. You can just see that arm doesn't become too tight. It is just relaxed, but it is also not collapsing well. Number two. Number three, you have to always make 3 portals. We were talking about 2 portals. Always make 3 portals, because in arthroscopy, you have to see from behind and you have to see from the front. Always keep on shifting from behind to front and front to behind. You should be open to that idea, because if only you look from one side, you will be missing a lot of pathologies. Like we were talking about. We were seeing from the front, we see that the labrum is torn from 2 o'clock to 5 o'clock. But as we see from above, we see that actually we are able to extend the tear back to 7 o'clock. So it's important to identify the posterior lesions also. We discussed in morning, it is not only Bankart which is the symptoms. It is also the Hill Sachs and posterior labrum which is important. So when you do an arthroscopy, it's important to identify associated lesions. Just don't run after doing a Bankart. Number 3 important step is labral mobilization. I think that's very, very, very important. You have to really lift the labrum up and extend the labral tear. Never be satisfied that you have lifted up till 5 o'clock position. Always go till 6 o'clock, even 6:30. Mobilize that the labrum starts to float in front of you, so that when you take a bite, you are able to do a mobilization. Number 4 important step, and we were talking about it, is a south to north and east to west mobilization. Simple putting stitch like this doesn't help. You have to actually mobilize the labrum all the way up, and then take the capsule and bring it like this. The symptomatic pathology in a humeral head dislocation is IGHL, anterior inferior glenohumeral ligament. That's most important. And whenever you are just stitching it simply, you are actually not tightening the IGHL. You are just bringing the labrum back. Every time the ball is dislocating out, there is plastic deformation of capsule which is happening. So just bringing it labrum at the right position is not the solution, because the capsule is still loose, the ball will dislocate out. You have to make the capsule also tight, and the thickening of the capsule is called as AIGHL, anterior inferior glenohumeral ligament. Your bite has to be an AIGHL, and your mobilization also is AIGHL. It is not the labrum repair, it is a capsulolabral repair. So that's important. Number 5 important is try to use knotless anchors. If you put proud knots, the humeral head starts to rub on the knots, and slowly arthritis would happen. So try to use knotless anchors. If you are using a knotted anchors, the knot should not be on the labrum side, on the capsule side. It should be on the capsule side, on the other side. But we have seen, patient starts to move arm, slowly the knots would start migrating and come to the glenoid side. So whatever you may do, when you put a knot, throw a knot, tighten the knot, and you keep it away from the labrum, with slow movement of the shoulder, the knot starts to move and it comes on the articular side, and it causes arthritis. And that is why we have stopped using all knotted anchors for instability. And number 6, never use titanium anchors for instability. Never use. We have removed titanium anchors, patient have become arthritic. However well you put a titanium anchor, over a period of time, the cartilage will become thin. The titanium anchor tip will start becoming proud. It will start rubbing the cartilage, and patient will become arthritic. So in our instability surgery, titanium anchors are out, and possibly knotted anchors are also out. The best anchor is a knotless anchor. Now you can debate between a PEEK anchor or a biocomposite anchors. Biocomposite anchors have a problem. We do surgeries where company people bring these bio-knotless anchors, and they bring in their cars. Outside temperature, Patna, 45, 46 degrees. If they move from one hospital to other, the bio-knotless anchors become bad. So we have seen when we start hammering a bio-knotless anchors, they actually break sometimes. Because the direction is very oblique. When you do it is not like this. You are actually hammering it like this. Slight torque or angle will break the anchor. So we have actually stopped using bio knotless. Today we saw all peak anchors. So I know cost is a concern, but peak anchors are the best anchors right now. They don't cause any osteolysis. They don't break while putting it down. Imaging, no problem. You can do MRI, CT scans. And these are 2.8 mm, very small anchors. You can actually put 3 or even 4 anchors on the face of the glenoid very, very easily. So these are simple steps which are important for a Bankart repair. And I think we demonstrated all of these steps one by one in our live surgery. So if there's still any questions, free to answer your questions, both for the massive rotator cuff and also for instability surgery like Bankart.
Thank you very much.
Yeah.
Do these behave as normal, or do they have some component of biceps?
I think he's got an excellent question. And that is why for a biceps SCR, there are two techniques. The one I showed is called as biceps SCR in continuity, which means I don't do a tenotomy. You release the biceps from the groove, you take it out from the groove and then stitch it. We do it in the condition where I think after releasing the biceps is healthy, it is not inflamed. It will not cause any problem. If I think the biceps, I release the bicep, it is red, inflamed, it will cause problem. I cause a tenotomy. The proximal stump of the biceps, I use it for SCR. And distal stem, I will just make a small incision and do a sub-pec tenodesis. So even the biceps function is good, and proximal is used for a SCR. So that is how you do it. But if it is inflamed, then you always do a tenotomy, separate, remove that part which is bad out. And if it is not inflamed, you actually do a biceps SCR in continuity.
Thank you, sir.
Any more question? Thank you.
Thank you very much,
Thank you,
sir.
Dr. O'Brien.
Thank you, sir.
For very important tips. Thank you very much. Now this is the end of this session.
Thank you, chairpersons. I request our chairpersons to give a memento to the speakers of this session. Both of you can combine, give it to Dr. S.S. Jha, sir, please. Dr. IPS Oberoi and Dr. Arvind Gupta. Mahesh, you can also have it. Yo, come on. इसमें क्या है? It is आज जा आप ही दे दीजिए चेयरमैन को।
Hello.
May I request our most important BOA person
It's
now,
7K.
Rajiv Anand, to give a memento to our chairpersons.
7 दे दो.
Meanwhile, we will have lunch. Live surgery will start somewhere between. Requesting Arvind Gupta and Abhinav
Start
to
a
have lunch
transmission.
first, because any moment they
उधर
give
से
a green
सुन रहा है?
signal
Am
from
I
our
audible?
OT, we will start the live surgery. So even if it starts, you can have your lunch. And ठीक है, let's start. 5 मिनट बोलिए ना, 5 मिनट delay
I think after 5 minutes, he will be explaining the MRI and about the patients.
So please have, if many of you can just sit here, because don't have any rush at the lunch part. We can sit here, we will get the live surgery on.
Am I audible? Who is
Moderators, again, very excellent. Difficult surgery, made easy, excellently performed. A bit difficult to understand if you have not seen the surgery or understood, but still, it was nice to see. We will go on to our last session of today, and then there will be workstation. To chair this session, may I request Dr. A.K. Manav sir and Dr. Ashwani Gaurav to chair this session.
So it's a most difficult session of any academic event, the post-lunch session. So most probably I shall be able to keep you awake, all of you. So most of the part of this topic has already been discussed or has been shown in the previous talks and in the previous surgery which has been done brilliantly by Deepak sir. So I will just try to enumerate or focus on some of the salient features of this topic. So like any other surgery, the majority of the intraoperative problems can be minimized through a thorough planning and proper surgical technique. So what are the problems we can face during this arthroscopic rotator surgery? Is, starting from the vision, then there may be the problem in the reduction of the tendon to its footprint, and then during the anchor placement and insertion, and the last one in the suture, during the suture management. So during the vision, for a better vision, we need this systolic pressure to be better to be kept around 90, or it's better if it is less than 90. If it goes beyond 90, then it creates a problem in the visualization, and we repeatedly lose the orientation of the surgery. So if we keep the systolic below 90 and the mean is around 60, then that's the best for the visibility. Next is tranexamic acid has been proven in the several of the, most of the literatures that it has a positive role in decreasing the bleeding during the surgery. And the last is unlike the knee surgery, we use the shaver very less in these cases. We mostly use the cautery or the cool cut or the RF probe. Next is the release and reduction of the tendon. Like the chronically retracted tendons like patties 2 or sometimes patties 3, it's sometimes becomes very difficult to release the tendon. In that case, we have to release the tendon subacromial space and also in the from the under surface of the tendon from the intra-articular side. So pre-operatively also we have to decide, and we have to keep the armamentarium ready, or regarding counseling for that also have to be done. If we are not able to repair the tendon, then what else we can do to come out of the surgery and to provide some of the relief to the patient. Alternative procedures has been already been discussed by Dr. Arvind, like what else we can do if we are not able to repair the tendon, then what we can do. This has already been discussed, that Patty's classification, if the retracted tendon is up to the glenoid level, or that does not create much problem like IPS sirs have said. We have also seen that by pulling that, if you are not able to pull that with the grasper, then you can put a traction suture, and by that we can pull it, and gradually you can release it on, like I have said, that on the subacromial side, on the intra-articular side also. The major problem is with that this is fatty degeneration of the tendon is there, then it becomes difficult to repair that. Sometimes the like in the previous case, the sir has released partly the coracohumeral ligament from that coracoid site. To avoid that problem, we can put the traction suture, like here I have put a fiber suture tape, and by pulling it I have confirmed that I will be able to reduce the tendon and I will be able to fix it to the footprint. Next is the anchor fixation. The stability of the anchor fixation is a prerequisite which is determined by the quality of the bone and the design of the anchor and its material. Like our expectation every time is that once we have put the anchor, it has a good hold in the bone, so that we can provide a good repair. But every time it's not possible. But this is our ultimate target. Like what I have done in this case, this is a bit over enthusiastic, but if it's like that, we are very happy that the hold of our anchor is too good. The whole body, the whole shoulder is moving by the pull of that anchor. Next is bone quality. It's not like that only in the elderly people we get the poor bone quality. If the patient is having a chronically torn tear of the rotator cuff, then also the bone quality becomes poor. If he is having the concomitant stiffness of the shoulder, like if the forward flexion is less than 40 degree or the external rotation is less than 20 degree, in those cases the outcome of the repair is very poor because of the poor bone quality, and it becomes very difficult to reduce the tendon also. Decortication of the bone and also the GT microfracture, this also reduces the quality of the bone and increases the chances of anchor pull out. If the anchor pull out starts, then it also depends on the type of the anchor. Like in this slide we can see that screen type anchors has a pull out rate of around 3%, and the all suture type has a 5%, but it appears here 3 and 5, but statistically it's not significant. This difference is not significant. So all suture anchors are equally stable, like it has been already been discussed. Like if we have a good cortical bone, then all suture anchors are equally good. So the intraoperative anchor pullouts are significantly seen more commonly in the larger cuff tear, because we have to put the more force, and in the women, in elderly patient, or the patient with the preoperative significant stiffness. So how to manage this pullout? If it is coming out, then if anchor which we are using are the screen type anchors, in those cases we can do the body screwing, though it increases the cost because you are using an additional anchor, but with this technique we can manage. In this we place a second anchor directly adjacent to the original anchor to create an interference field between an anchor against an anchor. So another is, if we are using the all suture anchors or the soft anchors, this can be done in the by shifting the place of that anchor to some other location where we can think that the bone quality is better, or we can go towards the lateral row anchors we can put and strengthen or that part. But if you try to put, sometimes initially we tend to do that, the bone quality is not good, let's go more lateral, but if you go too lateral, then that also hampers the outcome. Like it creates an windshield wiper effect, windscreen wiper, or the bungee cord effect, what we see in the femoral tunnel during the ACL reconstruction. The similar effect is seen also here, and gradually the healing of the cord is not better in those cases. So in these two diagrams we can see that the body screw technique, the another screw which has been used adjacent to the original screw, which was slightly coming out, the pull out was occurring. In the second one, rescue anchor, the lateral anchor has been applied, and that has given a substantial amount of fixation. One other option is the cement augmentation, the PMMS cement augmentation. It increases the pull-out strength, but it has its own disadvantage because it decreases the bone surface for the adequate healing. 2 minutes more. So it increases the bone healing surface, and it also obstructs the bone marrow which comes out of that canal. So it's least preferred. Another is a newer technique which is called a BASP BAS, the bar anchoring using a threaded Steinman pin.
Please
this
keep
is
to the
very
time.
rarely. Pardon.
Please keep to the time.
So 1 minute. Sorry. This is only for the theoretical aspect, because I have not seen it, I have not done it. But for theoretical aspect, we can use the Steinman pin of 2.3 mm diameter, which we use in the fingers or the metatarsal. That can be used as an anchor. Like Dr. Sandeep has mentioned, he likes to put the anchors at a 45 degree angle, that is the dead man's angle. But nowadays literature is saying if you are putting it at the 90 degree angle perpendicular to the bone, it has the equally good outcome compared to this. The concept which was given by the Burkhardt. The depth, sometimes we tend if it's not holding, go little more deeper, but that also decreases the outcome, that decreases the hold of that anchor. Suture management. During the surgery, it has also been discussed, while pulling out the suture, we have to keep an eye over the anchor. Like in this photograph, we can see that the two difficulties are there. One, in the in the posterior anchor, we can see the 4 sutures are coming out, but in the anterior one, we can see that only 2 sutures are coming out. One has already been offloaded, and another thing is offloaded and it has entangled with another suture. These two are the complications we can see if you are not be careful during that surgery. So this entanglement initially, in the initial phase, definitely the surgeon feels like the man in the black and white if the suture entanglement start occurring during the surgery. The speed bridge technique, which is one of the implant is with the R3X, it minimizes the chances of suture entanglement. Not tying knock security, these also becomes a less chances if you are using the knotless sutures. Insufficient tensioning, over tensioning, both creates problem. And it is the dog ear, which has already been demonstrated in the previous surgery. It can also be treated with the separate suture, or we can use that with the extra suture which is provided with this swivel lock anchors. Thanks a lot, and sorry for the delay.
Dr. Piyush Sharma, and his topic will be post-op rehabilitation.
Good afternoon, everyone.
It is a request to kindly keep on time.
Okay. Today my topic to presentation is post-operative rehabilitation after arthroscopic repair of Bankart lesion and rotator cuff tear. Main thing is principle of rehabilitation is early motion to the extent allowable and is crucial to success. Strengthening should be gradual and progressive. Repetition should be increased first, followed by increase in resistance. And strengthening must be balanced. Stabilization activities and exercise with weight bearing like closed kinetic chain promote effective and functional strengthening. The deltoid, scapular stabilizers and the rotator cuff muscle each have unique mechanisms, and the exercise designed to strengthen them must take these into the accounts. An example is determining the best strengthening exercise, like the full can exercise can be shown to offer some advantages over the empty can exercise, particularly when subacromial impingement exists. The aerobic exercise has benefits nearly everyone recovering from the shoulder surgery. The exercise should be designed to address impairment and progress to approximate closely the desired level of function. The patient who smokes should be encouraged to stop smoking, at least to cut down during the post-operative period to the negative influence. This has to be healing. The graphs of range of motion and tracking repetition and weights of strengthening are helpful, especially when target for these related to the desired function. There are many tools to measure outcomes, like examples are the Western Alternative Shoulder Stability Index, simple shoulder test, disability of the arm, shoulder and hand scale, and the constant score, raw rating scale and pain shoulder score. Rehabilitation protocol after rotator cuff tear should be stressed that it is only a protocol and should not be a substitute for clinical decision making regarding the patient progression. Actual progression should be individualized based on your patient physical examination and individual process. The progression of active range of motion against gravity and duration sling use is predicted both on the size of tear and quality of tissue. It should always be stressed to the patient that although he or she may be pain-free, and most substantial gain will be seen in first 6 months. Rotator cuff rehabilitation is a long and slow process. There are many phases to start with the rehabilitation. Phase 1 consists of immediate post-surgical phase, the week 0 to 8 weeks. The goal is to maintain and protect integrity of repair. The main thing in this is no active range of motion of shoulder, and the sling must be used for at least 8 weeks for massive tear size. From day 1 to 14, there has to be use of abduction brace and sling. You can see in the slide. During sleep also, remove only during exercises. And you should start with passive shoulder range of motion, flexion up to 100 degree, external rotation, internal rotation, scapular plane is less than 20 degree. We can use cryotherapy for pain inflammation from day 1 to day 7. These are the, there is also, we have to do flexion up to 130 degree, external rotation is 30 degree, and continue elbow and hand from wrist and fingers. Being scapular muscle isometric sets, which can be shown in the picture, can active range of motion. No running and jogging should be advised. Aquatherapy may begin approximately 10 weeks post-operatively. Criteria for progression to next phase 2 is passive forward flexion up to 125 degree and external rotation greater than 25 degree. The phase 2 starts with a goal not to allow healing of soft tissue. Do not overstress healing the soft tissues. there has to be no lifting of objects and not sudden jerk movements. You can see the from the week 8 to 10. These are the range of motion exercises, and first main thing is that may require gentle glenohumeral scapular joint mobilization as indicated to obtain full unrestricted range of motion. From week 10 to 16, these are the exercises can be done. External rotation and internal rotation with exercise band as sports cord or tubing should be allowed. Criteria for progression to phase 3 should be full active range of motion. Phase 3 deals with the early strengthening weeks from week 16 to 12. Goal is to achieve full active range of motions. So we can use full can exercises and may begin body plate flexibar bowing below 45 degrees. After that, phase 4 advanced strengthening phase. These are the main thing is this advanced proprioceptive neuromuscular activities should be performed. Initiation of light sports like golf, sweeping, putting, tennis ground strokes should be done. Now we come to the rehabilitation program for the Bankert repair. The consideration for the post-operative Bankert repair rehabilitation program. Many different factors influence the post-operative Bankert repair rehabilitation outcome, including the severity of damage to the labral and capsular structures and individual patient factors, including comorbidities. These are also divided into phase-wise, like immediate post-op 0 to 3 weeks. We have to give maintain upper range of motion in elbow and hand wrist. The sling has to be in neutral rotation. Use of abduction pillow in 30 to 45 degree abduction. Intervention we can do for the swelling management like ice compression. Range of motion exercise like hand squeezing exercise and shoulder shrug scapular retraction can be done without resistance. Criteria to progress into second phase is 90 degree shoulder passive range of motion, 20 degree of shoulder passive range of external rotation and internal rotation should be achieved. Palpable muscle contraction has to be there. Phase 2 is intermediate post-op like from week 4 to 6 weeks after surgery. Rehabilitation goals should be continue to protect surgical repair, reduce swelling. The sling, we have to start weaning out the sling. Precautions should be no lifting of heavy objects, and range of motions, passive range of motions have to achieve external rotation 115, and these are all given there. The strengthening should be periscapular like row on physio ball, we can see the in the image, and shoulder extensions and robbery and serratus punches. Criteria to progress, there has to be 135 degree shoulder passive range of motion and 50 degree, 45 degree, 115 degree. Phase 3 starts with intermediate post-op continued for 7 to 8 weeks after surgery. Rehabilitation goal is to do not overstress healing tissue and reduce swelling, minimize pain. Gradually increase shoulder passive range of motion. Initiate rotator cuff strengthening exercises. Sling should be discontinued. Precautions should be no lifting of heavy objects. Range of motion is given there, and a criteria to progress to the, we can use here the strengthening for resistant band, shoulder extension, resistant band, seated row. Criteria to progress to the next phase is given here. Phase 4 is transitional post-op 9 to 11 weeks after surgery. We can use the main thing is that proprioceptive neuromuscular facilitation. There has two types is there. The D1 is diagonal lift and D2 is also diagonal lift in opposite directions. Criteria to progress to the next is full pain-free passive range of motion and active range of motion. And phase 5 start with strengthening post-op 12 to 16 weeks. Criteria to progress a full. So last. Take-home message from this is to awareness regarding the type of injury and its impact on the activity of daily living, duration from the time of injury to start of the treatment, and role of early rehabilitation for registration of functional outcome before surgery, and they should stick to the protocol set by the physician. Thank you, sir.
Next, I would like to invite Dr. Kumar Anupam from Gaya. He will be speaking on post-op complications.
Thank you. I was doing a Bankart and I had a suture loss, as you can see. So as Joshi sir was showing during surgery, that you have to be careful that the sutures don't move. So this brings us to complications associated with shoulder scopy. Uh, Usually shoulder scopy is a very safe orthopedic procedure. In fact, amongst one of the safest orthopedic procedures to be precise. Chances of returning to operating rooms are very low until and unless you have done some gross technical error or something. You do see that there is a slight risk of mortality. It's just like saying ki, you go for a spine surgery and you may having kind of eye or a vision loss. So yes, do you think that you can have mortality in shoulder surgeries, shoulder scopy surgeries? Maybe we can come back to that later. Uh, Complications related to scopy in cases of shoulder surgeries is usually more higher than compared to knee, and they usually get underreported. Uh, Causes of mortality, maybe I'll start with the most sinister, most complication. Usually when we operate the patient in beach chair position and when we have hypotensive anesthesia, we end up having cerebral ischemia at times, and that can lead to cerebral desaturation, and that is the cause of mortality in rare of rare cases, maybe 1 in a million or something like that. So yes, one has to be aware about those things, particularly related to anesthesia. Another thing is hypothermia. Because the OT environment is cold, we make use of hypotensive anesthesia, and the irrigant fluid is at times cold because the temperature is around 16 to 18 degrees Celsius for orthotes. So that can cause patient discomfort, can result in myocardial ischemia, can predispose to surgical site infections, coagulopathies. So hypothermia is one thing. Many a times you can see that after scopy, our patient is shivering and all that. So we can always make use of bear huggers or warm touches for that. Fluid extravasation is also one of the causes. When I was at training under Joshi sir at Delhi SIC, and there was a case of rotator cuff, old female, she was being operated, and the surgery took quite some time because it was a revision case, and by the time the patient came out, she had a big dependent breast lump, and the patient had to be moved to ICU for observation. The patient came out well, but that is because if you use a lot of fluid and the pressure settings of your pump is high, so that can cause at times airway obstruction and maybe rhabdomyolysis as well. So you have to be pertinent about that as well. DVT in shoulder scopy is very low, amongst one of the rarest of complications. And we have to be pertinent in few cases like those who are suffering from cancer or have a history of coagulopathy and smoking, like that. Infection, as in other arthroscopy cases, is low again because we use a lot of water. Water acts as a barrier or kind of a washout for infection. But those who have had steroid injections or are diabetic or RA, we have to be careful about infection in such cases. Coming to more other kind of late complications like post-arthroscopic glenohumeral chondrolysis happens in those cases as a delayed outcome, especially in young patients who present to us that the surgery went well, early post-op phase was well, but later on what has happened is that the patient is developing deep pain and there is limitation of motion. So this can be because of proud anchors, as we were seeing in one of the cases, can be because of use of RF devices, excessive use of RF devices, etc. Axillary nerve injury, rarely, not very frequently, but can happen with inferior anchor placements. Also because of tractions, when we put our limb in traction in lateral positions. So has to be, it need not be very tight, as Joshi sir was telling. So yes, has to be dealt with. Error in diagnosis, many times, many complexes which cannot be diagnosed early on. And many times we get MRI reports that everything is all right, there's a soft tissue Bankart, but when you go in, as Arvind sir was telling, that don't rely on radiology reports, but read your films yourself. You go in, there's no glenoid loss, but at times it has happened that there is more than 1/3 glenoid loss, and then you have to change the plan intraoperatively. So risk factors for recurrence after Bankart: if age is young, you participate in contact sports, you have used lesser than 3 anchors, your technique has not been right, there's a substantial glenoid loss. So that can be risk factors. And again, for cuff repairs, complications like re-rupture, stiffness, and hardware-related complications can be there. So re-rupture chances increase if you have cuff tears which are chronic, long-standing, age is more than 65, fatty infiltration, all that has been dealt, got clear classification, read your MRIs, see on the sections that there is, the muscle mass is good. If you have massive or irreparable tears, if your repair has been done under tension, and that's why you should middleize your construct, need not pull it very hard. Implant related complications, as said, migrations, proud implants, suture tangling as happened in the last case, but sir dealt it very well. Enlargement of the pilot hole, that is why it was shown that you have to put it in correct angles. Suture losses, as I showed in my first video. And again, shift to biocomposite implants, PEEK implants instead of metal implants. Bioavailable anchors are the things which are in fashion today, not in fashion, but are the right things to use. But yes, they can also be associated with cases of osteolysis and chondrolysis. So to prevent all this, a lot of things have been said, but most important is pre-op evaluation, good clear operative planning, good backup instrumentation, need not hesitate to convert to open in case you're getting struck, keep up with your training, surgical skills pertaining to shoulder arthroscopy have a bit higher learning curve as compared to knee surgeries. Stage your rehab goals according to yourself and not impertinent to a fixed plan, and be aware of unusual complications, especially related to anesthesia, hypertensive anesthesia, hypothermias, as well as the orthopedic technical complications related to your surgery. Thank you.
Flap lesion and biceps tenodesis by Dr. Nishant Singh. Okay, Dr. Lethargic procedure and its indications.
Lethargic procedure is still relevant in the age of arthroscopy. I'll be speaking briefly on the indications, a surgical demo, and how to avoid complications. Now, we have seen that shoulder instability is a relatively common procedure, having a high incidence of approximately 24 per 100,000 persons per year, higher male preponderance, and more common in second and third decade of life.
Can somebody start the slide? Projection.
So the go-to option is the arthroscopic Bankart surgery, as we have seen so beautifully in the day. However, all is not rosy with the Bankart surgery. It has a relatively high failure rate ranging from 3 to 35% according to several studies at 2 years. And the main culprit here is the bone loss, which can be both on the humeral head side as well as the glenoid size. So soft tissue repair alone is inadequate for a patient with glenoid bone loss of greater than 20%. In the morning we had discussed maybe 18% or so, and a large Hill-Sachs lesion. The Hill-Sachs lesion is also a relatively common thing. It can be seen up to 57% in first-time dislocations and maybe as high as 94% in recurrent dislocators. The critical size of the Hill-Sachs lesion is debated to be 20.5% of the humeral head diameter. However, the more important concept is to realize the on-track, off-track concept and whether the Hill-Sachs is engaging or not engaging, which is diagnosed on an arthroscopy. So what is the solution? The solution is an extra-articular procedure like the Lethargic procedure, which was first described in 1954 by Michael Lethargic. It involves a transfer of the coracoid process with the conjoint tendon to the anterior part of the glenoid. Now, how does it work? The biomechanics, it increases the bony surface area of the glenoid if it is deficient. The conjoint tendon acts as a dynamic sling, mostly in abduction and external rotation, which is the position of dislocation of the shoulder. And third is the repair of the capsule and augmentation by the acromioclavicular ligament and the repair of the capsule itself. So there have been studies to predict the failures of arthroscopic Bankart lesion, which we have discussed in the morning as well. So this paper by Bag and Beaulieu et al., they came up with these high-risk criteria which patients are at high risk for redislocating after an arthroscopic Bankart. The criteria are patient age less than 20 years at the time of surgery, involvement in competitive sports like kabaddi, wrestling, rugby, etc., shoulder hyperlaxity. It can be diagnosed clinically by external rotation of more than 85 degree on the normal side. A Hill-Sachs lesion, if it is seen on the AP X-ray, it shows a higher size of the Hill-Sachs lesion. Loss of the sclerotic inferior glenoid contour. Patients with more than 6 points in this criteria had a chance of 70% of redislocation after an arthroscopic Bankart procedure. So this was their score, and out of total score of 10, in fact, a borderline of 4 was decided. If the score is more than 4, it is better to go for a Lethargic procedure. So this is how they classified the glenoid loss. So this score is basically based on clinical examination and X-ray radiology, simple X-rays only. It does not go into CT scan or any fancy MRI. So all of us can understand if the inferior loss of the glenoid contour cannot be seen clearly in this X-ray over here. Now the Hill-Sachs lesion, if it is seen even in the external rotation view, it can radiologically tell you that the Hill-Sachs is a large size and it has higher chances of engaging and being an off-track lesion. So with later progress, Giacomo et al. Came up with this score, the glenoid tract instability management score. This score does not include the radiology criteria of the previous score, but it included the evaluation on 3D CT and classified the lesion as on track and off track. So an off track lesion was given a 0.4 and all scores more than 4 were better treated with Letarge procedure according to this score. So this is a most simplified version to understand what is glenoid tract. Suppose the tire is the humeral head and the road is the glenoid tract. If both the humeral head and the glenoid, that is the tire and the road, are normal, then there is no engagement. But the humeral head in the second picture we can see is okay. But there is a small defect on the tire or the glenoid size. It may not engage and it is still an on-track lesion. In the third picture, the humeral head is also narrow and there is a narrow defect on the glenoid size. So these have chances of engagement. Similarly, if the humeral head is normal in size but the glenoid defect is large, there can be chances of engagement. And if both are small, then there is definitely chances of engagement, and these are off-track lesions. This is the same depiction on the anatomical view. If the Hill-Sachs lesion defect is larger than the glenoid tract, then the lesion is called as off-track and engaging, and it is better treated by a Letarge procedure. So we have seen these pictures also in the morning. This is how you calculate the Hill-Sachs interval. This is from the medial footprint of the rotator cuff to the largest defect that you can see in the transverse plane of the MRI. This is the Hill-Sachs interval, and then you calculate the glenoid tract on the largest fitting circle according to the inferior and posterior margins. You subtract the defect and then you multiply it by 0.83 because 83% of the glenoid area is in contact with the humeral head in normal articulation. So if the Hill-Sachs interval is larger than the glenoid defect, then that is an off-track lesion. So considering all these things in mind, why do we need a Letarge? We need a Letarge for a bipolar, engaging, or an off-track lesion, to simplify things. When there is a severe glenoid bone loss or an inverted pear-shaped glenoid or more than 20% glenoid bone loss, or there is a case of revision instability after an arthroscopic Bankart repair, then those are indications for a Letarge repair. Now, how to avoid complications in the Letarge repair? The common complications that we are worried about are neurovascular injuries like axillary nerve or musculocutaneous nerve. If you do a thorough pericoracoid release and there is no stretch while mobilizing the conjoint tendon with the coracoid process, these nerve injuries can be prevented. Now, graft malposition. If the graft is positioned too superior, it will not prevent the dislocation. If the graft is positioned too lateral, it can lead to osteoarthritis and impingement. If the graft is again positioned too medial, it won't serve the purpose. Again, fixation with screws. If screws are too lateral, screws can cause impingement. If screws are too medial, it can cut out through the graft. So the important thing while doing a Letarge procedure is to have a good knowledge of the anatomy. Do a very nice exposure, spend your time, place your retractors well. I'll be showing a small video on Letarge procedure. If there is any doubt on placement on graft, on placement of screws, you should use the C-arm. If the graft fails, if the graft fractures while putting in your screws, you should have anchors ready to use. And arthritis can be prevented by a lateral overhang of the graft, by avoiding the lateral overhang of the graft. Now this is a cadaveric demo of a Letarge procedure. You can see the incision mark. It's a small incision, relatively 4 to 5 centimeters only, starting from the coracoid process going towards the axilla. Now once the incision is given, we need to develop the deltopectoral plane. You can see the cephalic vein so beautifully here. It can be demarcated by the fat. Even in live surgeries, wherever you can find the fat, you can see the cephalic vein easily. Once the deltopectoral interval is developed, then you can go deep and identify the conjoint tendon. So now we have gone more deeper, and now we are trying to identify the conjoint tendon, and self-retaining retractors are applied. Just 2 more minutes, sir. Now this is the coracoid process with the conjoint tendon beautifully. You have to separate planes on the medial and the lateral side of the conjoint tendon. Now one important thing to remember is we should not venture too far medially towards the coracoid process, because entire neurovascular structures, the brachial plexus artery lies medial to the coracoid process. So don't go beyond medially towards the coracoid process. Here we can see the conjoint tendon is beautifully isolated and released on the inferior aspect. Now we'll delineate the coracoid process till its base and measure the see the other attachments which need to be released. The pectoralis minor has been released from the medial side, and the coracoacromial ligament will be released from the lateral side of the coracoid process. This is the CA ligament. This needs to be preserved and can be augmented to the capsule while doing the repair of the capsule at the end of the procedure. So here the CA ligament is being taken away. The pectoralis minor has already been taken away from the medial side, and you have to stay close to the bone while taking away the pectoralis minor. Now, before doing the osteotomy, we measured the length of the coracoid process. It should be approximately 2 centimeters. And once it has been mobilized well, you have to decorticate the posterior aspect of the coracoid process. Here we can see the sleeve. Now we'll go to the subscapularis and identify the inferior 1/3 and the superior 2/3 junction of the subscapularis. This is the inferior 1/3 and posterior superior 2/3 junction of the subscap, where the rent is being made and the plane is being developed between the subscap and the capsule. Once we develop this plane underneath the subscap, we'll identify the shoulder capsule and place a vertical incision on the shoulder capsule. Then you can put your Fukada in and retract the humeral head. Just a minute. Yeah, so the Fukada has gone in, and now you need to clean the glenoid neck where the graft is to be positioned. Nowadays, a lot of companies have come up with these sophisticated devices which have an offset guide and help you aid better in putting parallel screws, so they can be handy. Otherwise also you can do the surgery without having these kind of offset devices, but they help you in determining accurate screw position. So that's it. Now you can put 2 screws, and this is how a post-op X-ray normally looks like. So contraindications for Letarge would be a voluntary instability, subscap tears, and glenoid fractures more than 30% bone loss. They need a bigger bone graft from iliac crest or other sources. That's my acknowledgements. Thank you.
Thank you. We had a wonderful session. I would like to invite all the speakers to come on the stage for any questions from the audience.
To give mementos to our speaker, Rajiv, please go now. Kumar Anupam. Abhinav. उनको एक दे दो बोला. And Piyush. May I request our president? May I request our president, sir? President, sir. चला ये chairman को दे दीजिए, sir. Our chairman to give memento to. Thank you very much. We will. There will be a very short knot tying station. If all of you are interested, Abhishek Das, you will be demonstrating. And any of you would like to try, you can try it. Abhinav, कहाँ गया? आर्थेक्स क्या हुआ? लाओ दिखलाओ। चलो हाथ दिखलाना है।
दो जो मोस्ट इम्पॉर्टेंट नॉट मुझे लगता है, एक है निकीज नॉट जिसमें कि यू गिव ओवर अंडर हाफ इंचेस और बहुत ही अच्छा स्लाइडिंग नॉट है फॉर बिगनर्स। इट इज़ वेरी गुड, वेरी सिक्योर नॉट। उसमें व्हाट वी डू इज़, अनफॉर्चुनेटली हमारे पास अभी नॉट पुशर है नहीं, बट व्हाट वी विल ट्राई टू डिमॉन्स्ट्रेट कि से अगर आपको प्रैक्टिस करना है तो ये सूचर्स काफ़ी कॉस्टली रहता है, अदरवाइज आप शूलेस से भी प्रैक्टिस कर सकते हो। तो व्हाट वी डू इज़ we pass it, and then you will have to decide which is your post and which is your the sliding suture. So जो भी आपका गया हुआ है through the tissue, you hold it as a post and keep it small because you will be pulling on it. So though it is called a knot pusher and you are pushing the knot, but in essence you are actually putting the throws and pulling it. So this is my post. I've held it shorter. अब इसमें एक, फिर दूसरी बार ऐसे. So you have got two throws here. One more throw again like this. There. अब आपका knot pusher यहाँ पे रहेगा. What you do is you start pulling on it and you will see that it gets tight. You will have to leave this one. इसको अगर आपने pull कर दिया तो बीच में ही अटक जाएगा knot. So you will have to be very careful कि आपका post कौन सा है and sliding part कौन सा है. You throw it with the sliding part, then release it and you pull on it. उसके बाद जो knot pusher है उससे आपने इसे push किया. Make sure that it sits on the tissue, it is tight. Again, you can do over. अब ये slide नहीं होगा because you have put the knot. So now you'll have to just hold the post with your knot pusher. You just put it, and then there's something which is called pass pointing, which is nothing but, you know, a way of securing your knot. So you just pass point the tissue like this. तो ये एक over था, then we go under, फिर एक दूसरा ऐसे लिया. Now the most important bit is जब आप end में आते हो, then you will have to flip the knot, जो कि डॉक्टर दीपक जोशी सर ने बड़ा ही अच्छा दिखाया था, when it locks the knot actually. So say I put, this is my last, so what I do is 3 hitches first, then 1 over, under, over, or 3 or 4 maximum. जो मेरा last रहता है, there I have put it, go till the end, tighten it, and in the end I just pull this one. So you tighten this, but the post you'll have to pull it hard and the knot will flip. There's sometimes what happens कि flip अच्छे से होता नहीं है, but if you pull it hard, this has to flip. यानी कि ये post अब आपका lock हो गया है, ठीक है? When you are not doing on the tissue, it's very difficult to demonstrate the flipping bit of it, ठीक है? But जब आप knot pusher से करते हो, in the end, make sure that you just hold this one and pull it hard. So ये आपका एक nicky knot हो गया, ठीक है? एक और demonstrate करूँगा मैं, which is a Duncan's loop. So again, you pass it through the tissue, keep it like this, put it on your thumb, then make a U loop like this, 1, 2, and then you bring it and pass it through the loop, okay? Now, what you do is you dress your knot, so you can make your hand like this, you dress the knot, okay? Now again, you leave this one and you pull on this, okay? As you pull, it's getting tight and tight. Obviously, then you have your knot pusher, you push it, make sure it sits on the tissue. Once this is done, you are safe. Now what you do is same again, I always do 1 over. Now this won't slide, so you'll have to take your knot pusher, put it up to there and then pass point. Pass pointing is important because otherwise your knot won't be secure, it will be loose, okay? उसके बाद एक over, then you do 1 under. Again, you put your knot pusher here, tighten it, and pass point. In this knot, it won't flip. Okay, so flipping is one of the things which happens only in the Nikki's knot. That's what I have felt. This is my personal feeling. I would ask anybody of you if you have had any other experiences. Rajiv, do you feel that this knot flips? This knot doesn't flip. I have tried it for some reason. It is only with Nikki's knot. This knot is very, very secure because initially what you have done is you have sort of secured your loop very, very, very nicely with some threads with the suture passing through the loop. So this is one which I use, very commonly in rotator cuff repairs in the medial row. In the lateral row, normally I use the knotless ones, but sometimes if I have to use a knotted one, then I use the Nikki's knot. But you can interchangeably use whatever you do. Learn one knot, make sure you practice it again and again, and then only go and do it in the patient. Because once the knot gets tied up here, it becomes a very painful thing to undo it. So, Abhinav, do you have any more sutures? Anybody of you like to practice, then you can come up here and practice. So it is very simple. Make sure what is your post, what is your sliding part. Okay, so the one which has gone through the tissue, make sure it is your post, make it short, and then you just pull on it.
All the faculties who have taken the untiring effect. I thank our president and secretary of Bihar Orthopaedic Association who have been there for all the help that I required all the times. Very, very thankful to Dr. Rajiv Anand being my friend, my associate all the time, and also providing me with the OT facility and this which we had such a wonderful live surgery. I do thank all my postgraduate senior residents of Patna Medical College and other faculties who have always been working hard to make this a successful. All the delegates who have come from far part of Bihar. Hope you all have learned something from it, and all of you would like to continue with knotting technique. Will consult Abhishek there, and with this we come to an end to this program. All thank you very much. All the sponsors again, thank you very much.